I am Gary Horndeski, MD, board certified plastic and reconstructive surgeon, and author of Weight Regulation and Curing Acquired Obesity. This is the fourth of 5 lectures on weight control and obesity. I'm going to talk today about the abdomen-gut-brain-axis weight regulation. Prior to my plastic surgery training, I was a board certified general surgeon. General surgery covers multiple end-top regions, including the abdomen. One of the most frequently performed general surgery operations is herniorrhaphy. Hernias are complete mechanical failure of a portion of the abdominal wall, which allows the intestines to displace through the defect to the undersurface of the skin. General surgeons also incise the abdominal wall when performing intra-abdominal surgery. Despite multiple operations on or through the abdominal wall, the importance of the abdominal wall in weight regulation has gone undetected. Similarly, internal medicine physicians have known about the gut-brain axis for decades. The stomach is often graphically illustrated in physiologic textbooks as floating in space with only intragastric contents shown. One of the earliest studies of the gut-brain axis placed electrodes into the vagus nerve of cats. When a glass rod touched the external surface of the stomach, there was increased firing of the vagus nerves. Despite these observations, the significance of the abdominal wall and abdominal contents in generating pressure on the stomach's external surface has been neglected. An analogy of the relationship between the abdomen to weight and the relationship of the thorax to ventilation can be drawn. Lungs transfer oxygen to the blood, but the muscles and bones of the thorax produce mechanical forces that regulate oxygenation. The abdominal wall and abdominal contents produce the mechanical forces that regulate weight. Abdomen-gut-brain-axis weight regulation is based on control system theory, physics, and physiology. As described previously, intra-abdominal pressure is generated by the abdominal wall stiffness times the sum of meal volume plus fat volume plus non-fat volume minus volume capacity. Within the two-dimensional curved surface of the stomach, tension is developed, which equals intra-abdominal pressure times the stomach radii. Within the stomach wall, IGLEs convert wall tension to volume, with volume equal to tension times K. The volume signal within the negative feedback loop is sent by the vagus nerve to the brain. The volume signal contains two components. Non-fat volume minus volume capacity is a fixed negative volume within the volume signal, which generates a positive volume dependent reference signal. The second component of the volume signal is intra-abdominal fat volume, which indirectly senses total fat volume. What evidence supports the abdomen-gut-brain-axis weight regulation? First, special occasions and holidays such as Thanksgiving are often celebrated with feasts. Abundant foods allows people to eat excessively. We have all experienced increased intra-abdominal pressure after meals. Eating beyond satiety creates a sensation of the inability to breathe deeply due to elevation of the diaphragm. Abdominal expansion may cause clothing or belts to create skin compression. In extreme cases, patients present to the emergency room complaining of shortness of breath or abdominal pain. Second, previously I discussed my personal observation and those of Dr. Marquez after mesh reinforcement abdominoplasty. Abdominoplasty with mesh reinforcement decreases abdominal volume capacity and increases abdominal wall stiffness. Patients report reduction of weight from small meal volumes producing satiety. Third, liposuction produces permanent weight loss. This is consistent with sensing only intra-abdominal fat volume, since extra-abdominal fat is removed. If total fat volume was directly sensed, then compensation with return to previous total fat volume would occur. Previous theories of weight regulation based on directly sensing total body fat have failed, such as leptin. Fourth, the World Health Organization length and weight for age graphs support the concept of weight depending on two components, a fixed component and a variable component depending on L cubed, which corresponds to volume. Abdominal gut-brain axis volume regulation model has one fixed reference and a volume-dependent reference. Fat weight equals 0.9 times fat volume, and the total weight is the sum of fat weight plus non-fat weight. Fifth, placing a gastric balloon increases intra-abdominal non-fat volume, resulting in weight loss as predicted. Sixth, in a clinical experiment, patients were placed on liquid diets for several days. The volume consumed for each meal was determined. After the feeding pattern was established, the patient had a tube feeding of an unknown volume 30 minutes prior to the scheduled meal. The volume consumed at next meal was reduced by exactly the volume of the previous tube feeding. Then the caloric content of tube feeding volume was determined. The next day before their meal, they had an intravenous infusion of the same caloric amount as the previous tube feeding, but the consumed volume was not reduced. Calories were not sensed, volume was. Seventh, in 1985, Dr. Koopman published Internal Signals Create Changes in Food Intake in One-Way Cross-Intestine Rats and Brain Research Bulletin. In this study, genetically identical rats were sewn together side by side over the abdomen to create complete blood exchange. One rat in each pair was a donor and the other was a recipient. Approximately 15% of the recipient's small intestine was interposed before the donor's small bowel. As a result, food eaten by the donor entered the donor's stomach, passed through the donor's duodenum, and then into the recipient's small bowel. Whatever wasn't absorbed by the recipient returned to the donor's small bowel. The recipient had normal gastrointestinal tract except for the transposed segment. The recipient received nutrition from his meal and the donor's meal. If only stomach volume created side, then both rats should eat the same volume. If a blood-borne chemical controlled the volume, then both rats should eat the same volume. The observed result was that the donor rat ate much more than the recipient rat. Dr. Koopman concluded that internal signals were generated from either the stomach or the intestines. It was also observed that there was an inverse relationship between the meal volume and total fat volume. This animal experiment is consistent with the abdomen-gut-brain-axis for volume regulation. Eighth, Prader-Willi syndrome is a rare genetic disorder that creates obesity. Prader-Willi syndrome patients have poor muscle strength, resulting in weak abdominal walls and increased intra-abdominal capacity. They cannot generate sufficient pressure intra-abdominally to achieve satiety. They are always hungry, overeat whenever possible, and may rupture their stomachs in an attempt to achieve satiety. In summary, animal and human studies support the weight regulation by abdomen-gut-brain-axis. Understanding weight regulation physiology allows a scientific approach to the pathology of obesity and its treatment. Thank you.